there's so many things that I was thinking about commenting on, but I think I'll try to keep it brief. One, the sort of fundamentals that you're talking about, wearing masks, washing hands, the surveillance approach, and I think those have been so key. And at the beginning, there was this tremendous fear, and I think my fear was our employees were going to get COVID-19 at high rates. And I think as we're going to transition to talking about mortality and end of life, I think that was my biggest fear. It remains a major fear that we are going to have our employees at risk. And while we recognize there is risk in healthcare, and all of us are taking risk, especially frontline employees, the reassuring thing we've seen is that we are not having healthcare workers get infected at high rates in any way. In fact, I think of our 2,000 employees, we have approximately 2 that have been determined to have work-related exposure. So that's, I think, 0.1%. And the vast majority of our employees that now, I think we have about 30 that have developed COVID-19 have got it in the community, meaning from their family members, their children, their social interactions, et cetera, which is just a reminder that the basics work. And so, you know, it's kind of a simple message, but it's very important. And then before I transition to Dr. Dalton, I just wanted to recognize at BCH, the fundamentals are different than other places. I've worked at a small Harvard hospital in Boston that didn't have an infectious disease doc at all, 0. So if you needed one, you had to transfer them to the larger hospital. I know another local community hospital about our size in this area that has internal medicine docs like several of us who are not infectious disease trained doing infectious disease consultations. At Boulder, we have 4 docs and a nurse practitioner, and I can say with confidence, they're all outstanding. And I can't emphasize that enough, that makes a difference. And, you know, maybe that's not the most financially beneficial, you know, because it's expensive to have infectious disease docs. It's been crucial. And I think the support that we've had administratively predating me and Rob also has really been crucial. And Mark, I just wanted to thank you and Dr. Turner, Dr. Meditz, Dr. Pouget, and Alicia Maltzman. Did I forget anybody?
We also have a nurse in our office whose name is Natalie Macaro, who early on did a lot of phone calls to patients with this very terrifying information of you're either positive or negative for coronavirus. And so she took a lot of that on and really was a tremendous help to us as we were trying to do a lot of other things in terms of preparedness. Our medical assistants have largely done all of the employee health testing of sick employees at BCH. They took this on really upon themselves, and they take pride in making sure that they're working to make sure our employees have the easiest access to testing. And then our front desk has been tremendous in trying to deal with, we see a lot of patients in our office still because a lot of what we do needs a little bit of hands-on, and it's a little harder to do some of the telemedicine. And they've just been really tremendous in making sure our office stays safe and comfortable. And so it's really a tremendous team effort, and you know, I'm really happy we get to work in that environment every day.
Yeah, it's been a real asset, and I can't be more grateful that we have this resource available for current and future pandemics. Okay, so I'm going to transfer to Dr. Dalton, and this area is a little bit of an area that I know Dr. Cruse and I especially have had an interest in as well, which is talking to patients about what matters to them, and especially when it comes to end-of-life care. And I think everywhere, not specifically to BCH, this has been a gap where we either often don't ask our patients, sometimes we ask but don't document it clearly, sometimes we ask and document it and then it gets lost. And so we've really worked hard on all of those approaches. So maybe Dr. Dalton, you could talk a little bit about how that's changed as everyone's thinking so much about their mortality.
Yeah, so this pandemic has definitely ignited our institution to have more conversations and collaborations with our patients, the community, and providers across the states. Too often in the hospital, I have the situation where daughter said, I don't know what my dad wants me to do. We never talked about him needing a ventilator. So what we learned throughout this is that patients' voices need to be heard, and they need to be directing their medical care. So our inpatient and outpatient teams have collaborated more now than ever and have devised a set of educational tools to initiate these conversations, to document, and to bill for them. I think it might be helpful if I do a little background on palliative care and advanced care planning. So palliative care is a specialty in medicine that focuses on the prevention and relief of suffering experienced by patients with life-limiting illnesses through all stages of their disease. This specialist works with an interdisciplinary team, including chaplain, nurses, and social workers, to address the physical, psychosocial, and spiritual needs of both the patient and the family. The other main objective is establishing goals of care, keeping to the patient's preferences and values. I've been often asked by my patients, what exactly is advanced care planning? It's a process that enables individuals to make plans about their future medical care. There are two methods in which one can communicate these preferences. First is to complete an advance directive. Here in Colorado, we use a MOSE form. This tells medical providers like myself whether to administer CPR in an emergency situation or their wishes at the end of life on the types of medical treatments they receive. A medical durable power of attorney is a legal document you sign naming someone to make your healthcare decisions if you can't for yourself. So on the inpatient setting, our palliative care team now auto consults on all COVID positive patients to have these conversations early and to provide support. So that way, if my patient was to decline, I now have the documentation validating their wishes. I think we've also made an impact on the ambulatory setting. We're actually doing a pilot study with Dr. Lysette's clinic on pre-advanced care planning discussions before patients go to their annual medical wellness visits. So one of our palliative care members calls a patient and it introduces advanced care planning. They then remind them to bring their documents to their appointments. Though it's early in the study, it has been successful as patients have better understanding, less fear, and are actually completing more of these documents. Studies actually show that if we have these goals of care conversations earlier, it's associated with improved quality of life, less distress, and positive family outcomes. It also reduces the use of non-beneficial medical interventions and costs at the end of life. The other thing, as you alluded to, Ben, was that these documents, we don't want our patients to have these conversations over and over. So what we've done, our healthcare information management team is now scanning all these documents into one location in Epic, our medical record. So that way it's an easy and uniform way for all of us to find this information. So if I admit a patient to the hospital, I can click on a button and see that Mr. Brown doesn't want heroic measures such as CPR, because this was already discussed with his primary doc, like Dr. Dodson or Dr. Cruse. And so we're doing the work, but we need to make sure that we're capturing this information. Before, I would have these conversations with my patients, but wasn't billing separately for them. They just fell within our routine documentation. We have a new ACP document with a template that I can fill out during my rounds and then automatically bill.
Thank you. That's really helpful. And it almost seems crazy that we have to talk about the fact that we used to sort of lose these documents because we had different electronic medical records in the clinic and in the hospital and even between clinics, and then also UC Health or Avista, et cetera. And we have begun to solve that problem, which makes me very grateful because, as Dr. Dalton said, you don't want to have these conversations repeatedly. They're hard conversations, And I just want to address the billing issue that Medicare has prioritized and allowed us to bill. And maybe it seems elementary, but when you have the time carved out, then you have the conversations, and maybe you spend a little bit more time and you're a little bit more thoughtful. And so this is really important, not just to get us reimbursed, but to allow us and you as patients to have these conversations in a thoughtful way and not feel rushed. So in fact, in the clinic setting, you can schedule a visit only for that conversation, nothing else. You can say, oh, we'll do a physical and then I'll come back and I'll talk about advanced care planning. And you're not rushed, we're not rushed. And we also have nurses and other people that can help us with these conversations. So it's really a building process that's greatly expanded throughout COVID, and we hope to continue that. In the interest of time, I'm going to kind of quickly talk about collaboration. And Mark mentioned that, and I think there's been strong collaboration across systems. For example, all the chief medical officers from all the systems in Colorado, these quote competitors, were meeting daily for the first few months and now 3 times a week, and no competition at all. We're sharing protocols, we're sharing information, data, we're talking about transferring if necessary. That's occurring across CMOs, infectious disease docs, CEOs, and then I think just as importantly, the Boulder Public Health Department and the CDPHA, which is the Colorado Department of Public Health, have all been involved in these conversations. And so one, sort of small but really cool collaboration that I'm excited to sort of announce right now is Boulder County Public Health reached out to us a couple weeks ago and said, we have some money and we would like to institute a mobile testing unit where we can go to at-risk populations, congregate care facilities, homeless settings, hard to reach populations throughout the county. Are you interested? And we said, absolutely, what a great idea. And so as of October 12th, we are going to be collaborating with Boulder County Public Health and with a donation from Gephardt Volkswagen. We're going to be having a mobile unit that BCH is going to staff and send people out to the counties arranging the locations. And we're going to be swabbing and testing all these hard to reach populations. We hope and expect that will morph to flu vaccinations and maybe COVID vaccinations. And who knows where that will go, but it's a very strong collaboration with the county, and the state is funding it through the county. So it's really a cool, small example of what you can do when you start talking and collaborating, and we're excited to do more of that. And I think with that, in the interest of time, I'm going to open it up to questions, and maybe Grant will read those.
A couple of things. One, with the uptick in cases with our students on the Hill, are we seeing a downstream effect in hospitalizations? And then 2, with the expertise of CU BioFrontiers and all the other labs in the community, what do you see as the future of PCR testing and antibody testing this fall?
So I'll take on the first part of that question. Have we seen an increase in hospitalizations related to the increased number of cases that we've seen over the last few weeks related to people in the age group of 18 to 22, a lot of it associated with university students, and we have not seen that as of yet. Fortunately, the age range that's been affected does tend to have a lower risk of severe illness. It's not a zero risk, and so young people do get sick from this disease. So the idea that's out in the popular media often that young people don't get sick from this disease is not accurate. They just don't get sick from this disease as often as people in older age groups or with other underlying illnesses. What we have seen in the last 2 weeks in Boulder County is that the rate of disease in other age groups, so the younger age group from age 10 to 17, and the age group from 30 to 54, the rate of disease in those ages doubled. And so that suggests we're starting to see secondary transmission likely from those younger people that have had disease. And so if that continues to percolate and spread within the community, then the next thing we'll see is people that are over 54 being affected, or patients in a skilled nursing facility, which is a substantial risk population. And so even though we haven't seen things yet, our concern is that we're at high risk to potentially see that. Now is the time to turn that tide, because if we continue with the status quo, the likelihood those things are going to occur is substantial.
And the second part of the question around testing and evolution of that?
Yeah, so I wish I knew the answer to that. The evolution of testing in this disease is, as most of you know, has evolved in a very rapid time frame. So when we first started getting tests, I had to call the state health department and get them to approve a test for the right person with the right risk factors, and it took about a week or so to get the results back, which was tremendously frustrating as a healthcare provider and for the patient. Testing at BCH, I think it's important that people understand the testing at BCH as well, because BCH has really, in my mind, been on the forefront of testing for a community hospital. And so in our community testing, we now have on average a 24-hour turnaround testing time with PCR-based testing. And that's with the swab that people think about as being, the nasopharyngeal swab that people refer to as, my brain was biopsied, et cetera, et cetera. It's really not that bad. It's not fun, but it's not that bad. We're morphing away from that, I think. So what we're finding is that we need to be faster. And so the information we get from a test that's 4 days old is often not that helpful, because the person's either recovered, the person's getting sicker, but they may have spread it to however many other people. So you really want testing at the point of care. That could be your house, that could be your doctor's office, that could be your workplace. We're not quite there yet, and we don't quite understand this well enough. But if you would have asked me 4 months ago, should we be considering these rapid tests that don't perform as well as the gold standard PCR test, I would have said, you're crazy. We can't do that. And my mindset has changed entirely. And so there are people in the epidemiology world that really think we need to start doing tests that may not perform as well. So instead of telling you 9 out of 10 times somebody has it, they only tell you 8 out of 10 times. We may have to accept that, because if we could do it fast and often, that's better. And so what we want to find are the people that are really contagious. And so if we're testing frequently and are able to find 8 out of 10 of them, we're going to find the people that are at the highest risk of spreading it to other people. And so that's the key. So I think we are going to see some adaptability where we move to fasting, easier, less cumbersome testing methods. Are they going to get you back to going out to see the Broncos play or the symphony? I don't think that's on the horizon just yet. But I think we're going to start to use rapid tests with more frequent testing of people who are not symptomatic. Yes. But I don't think we're quite there yet. What method that's going to be, I'm not sure. It could be a PCR-based method, could be what's called an antigen-based method. But I think we're going to get simpler rapid tests that will allow people to have a little more ability to do some of the things that are more, quote, normal. But I think it's going to take a lot of thought and logistics to pull it off successfully. But it's one of those things where you have to take a risk and see how it works. And college dormitories, in my mind, are the place that you could try to understand this technology best, because you have lots of people with disease and you have easy ability to test them in a simple fashion.
With the rise in telehealth and acceleration within our system, what's happening at the state or federal level that's going to allow that to further expand going forward? Or what would you like to happen at the state or federal level to allow that to expand going forward?
I don't know. I can say what I would like to have happen. I can speak to what's happening with our payers right now. I don't know if you can talk at state level. I mean, I can say, like I sort of mentioned before, I think, I was joking the other day, and it's not really a joke, it's true. When I was a resident, how many years ago, 20 years ago, we were talking about telehealth and actually doing it up in Rochester, New York. And, still has not started, but we've just been talking about it for decades. Here we are, and we're doing it, and we are able to continue to practice and be financially stable, or more stable doing it. And luckily, the payers, the insurance agencies have guaranteed that they will continue to reimburse us for this service through the end of this year at least. And I'm hoping, and I know that there are efforts, I just know, probably like you guys have probably read about, that there are efforts at a statewide level to hopefully pass or create some kind of legislation that would support ongoing use of telehealth. I have no idea, though, where that is or how it's going, but I think as a provider, we would really like to continue.
Yeah, I think ultimately the issue is that we have to be paid for it to make it work. And I think if you look at Seema Verma, the HHS national leader, has indicated, I think she said, the genie's out of the bottle. We are probably not going back to a no telehealth environment nationally, but ultimately Medicare is going to drive that. I think Medicare has been signaling they're going to pay for this long term. There will probably be some limits, some guardrails. You don't want doctors to be charging patients a visit for calling them with lab results. That seems unreasonable. But you do want to be able to reimburse health providers for a real visit. And so ultimately, that's in evolution. I suspect it will continue. The guardrails will be decided primarily, I think, by Medicare, and the other payers will follow suit. And I guess I'll leave it at that. I just want to go back to the testing thing. I just want to give a little plug. I read today, I think we've done almost 20,000 COVID tests at BCH already. That's a pretty tremendous number when you look at, I think I read Britain's doing like 300 a day now. So we're doing a lot of COVID testing. That's been a very successful approach that we've had. And I think the ID team's been instrumental in that.
How are the new technology innovations that are occurring out there going to help, to enable successful telehealth or hospital at home?
I can speak just a couple examples. I had a new patient that just saw me in clinic last week who just moved from New York City to Boulder. This gentleman's probably in his late 70s. In New York City, his Apple Watch woke him up in the morning and said your heart rate was about 25 during the night. He went into his doctor's office and they said, if you had waited any longer, you might not be here right now. He got his pacemaker and he's feeling much better. And so I know the new Apple Watch 6 has the ability to do pulse oximetry. I think it's going to be, my understanding, you have to like wait 15 seconds and be really still. But, I think as we've all seen it with Apple, we've seen it with Android, we've seen it with all of those, I think people want more information about their bodies. They want more information about things. And I think, yes, you can sometimes get false positive stuff. Sometimes you're seeing the doctor, but I'd rather see somebody who says, hey, my Apple Watch said this and can listen to my heart and things are okay, as opposed to, something else. So I see technology as a good thing.
So if you've been exposed to somebody that you know is symptomatic, but you're not yet showing any symptoms yourself, do you recommend that people get tested or should they wait?
So if you're exposed to somebody with a disease in a close fashion, so that's defined as 15 minutes within 6 feet without, in the community, doesn't matter if you're wearing a mask, if you're just in close contact for a bit of time. And so the first thing is you definitely need to quarantine. And so that means you have to take yourself out of the public interactions for 14 days. Should you get tested after being around that person? I believe the answer is yes. And the best time to get tested is probably around 7 to 9 days after that exposure. So you don't want to get tested the very next day, because the likelihood you're going to be able to find virus that very next day in your body is very, very low. And so if you look at a kind of timeline of the virus as it starts an infection and progresses through an infection in a human, anywhere between day 5 and 9 is when the most virus is present. And so when the most virus is present is when you want to get tested. This was quite controversial recently based on CDC posting, don't get tested, and everybody said, what are they talking about? And then they said, okay, wait a minute, we made a mistake. I really do think that for public health purposes and to minimize the spread of disease, that's the best way to go about it, is to actually get an answer. Here's the bad news. If you get tested at day 5 to 9 and you're negative, you still have to stay in quarantine for 14 days. So we can't guarantee that our tests are 100% perfect. And so you're still stuck in that window of quarantine, but you can feel a lot better personally about, I probably don't have the disease at this point in time.
Excellent. Thank you.